Veera Khan. I'm a ST5 Neuroradiology Fellow. I'm working in Oxford, hopefully finishing training next week. And I've got my team with me today, and I've got two wonderful speakers who are going to speak on how to get into radiology. So we'll just start off with the introductions. So Angelica.
Hello, good morning, everyone. So thanks for joining us in this webinar. We're really excited to share what our speakers will have to say about how you can get into radiology. Just a few housekeeping rules before we begin. So obviously, if everyone could just keep their cameras off and their microphones muted, just to make sure that everything flows smoothly. And then equally, if you have any questions, feel free to type in any of your questions in the chat box, and then we'll try to answer them. And maybe when the speakers do have some time to answer, but of course they'll be talking. So yeah, they might just answer the questions at the end of this session. All right. And yeah, so to introduce our speakers today, we have our teaching coordinator, Sadaf. Sadaf, could you say hello to everyone?
Yeah, hi, thank you, Angelica. I'm Sadaf. I'm one of the teaching coordinators here at the UKRST. And it's my pleasure to introduce two of our speakers today. They both are incoming ST1s. And the first one is Alexander and the second is Omar. And I won't take up much time. I'll pass on to Alexander just to get the things going.
Perfect, thank you. Omar, should we share the PowerPoint screen then? Right, cool. All right, yeah. Hi everyone. Thanks for giving up your Saturday morning to spend the day with us. So yeah, my name is Alexander. I'm one of the incoming ST1s in the Northwest, and I'm doing my talk with my colleague Umar as well. So we were both in your position 12 months ago. We mainly used UKRSD for our preparations. We were even in the same interview sort of breakout room right up until the day of the interview. And I really can't speak highly enough of the team behind UKRSD, so I would definitely prioritize them for any of the preparations going ahead. But let's start then what we did and how we prepared. So should we go into the next slide? So today we'll look at the general sort of application cycle, the recruitment timelines, as well as a general overview of the radiology program. It's a little bit about nuclear medicine, and then some specific guidance to our IMG colleagues, as well as then focusing on the MSRA preparations for the second half of the talk. And we can give you some tips on what we found worked really well for us and how we sort of obtained the scores we did. Okay. So to start with some really basic things. So the application is via Oriel. For those of you who have not had a chance to have a look at Oriel yet, it is a website through which the Health Education England runs pretty much all the applications, be they for foundation training or core training or higher specialty training. To be able to apply, you have to have a full GMC registration and hold a license to practice at the intended start of the training. You need to have completed your foundation competencies. So if you've done your foundation training in the UK, that's valid up to 3.5 years after you've completed F2. If not, you will need a CREST form, which is also the form that you need if you're coming from abroad. And then finally, you also need to be eligible to work in the UK, and this includes meeting all the visa requirements as well as any HR requirements that may sort of come down the line. Okay, so let's have a little look at the actual recruitment timelines then. So this is focused on this year. It's just to give you a little bit of an idea in terms of where we are now and what you can do going ahead. So you should expect the advertisement to be published in October time. It's now the 20th of July. So essentially from this point on, there's around about 4 months within which you need to sort of start making a plan for what you're going to do going ahead to be successful. So the adverts will appear on Oriel. They will come out towards the end of October usually, and they're open for 1 month. And it takes about an hour and a half to sort of fill everything in, and you need to have submitted it by the end of November, your formal application. Following this, the next big step is the invitations to the MSRA, whereby if you meet all the basic requirements that we mentioned earlier, you will be invited to sit the exam. And this exam usually takes place in the first 2 weeks of January. The way it's done is it's usually done in a test center. So I did mine in Manchester. It's the same test center I actually did my driving theory assessment in. So it's just a room with a lot of computers in, and you do the exam in that kind of setting. It can be done from home. So after the MSRA, the next big thing that opens up is the evidence verification upload. Now, what's important to state, and we will go through this as well in a bit more detail later on, is that when you are applying, you also need to actually say what kind of points you think you score in the portfolio. And that evidence needs to be valid up until that point in November when the application closes. So the evidence verification is you uploading the evidence from what you have achieved up until November, not what you have achieved up until February. It can become a probity issue if you're basically applying for something that you think you will complete in the future. But that is the sort of next step in the process. Following that, the results come out. This usually comes in the sort of beginning of February, and this again has been a bit of a nightmare this year, whereas people who apply for multiple specialties. For example, I think Obs and Guy and EGP got their results earlier than the radiology guys and everything. So it's always a bit of a stress-induced week, so just be prepared for that, but it is what it is. Once you get your MSRA results, you will then, depending on those, be invited to interview. And again, we will go through the cutoffs this year as well as what the process looked like. But once the interview invitations come in, everything kind of goes at a very fast pace from then. So the interview, then you apply towards the end of February. It's already in about 2 to 3 weeks. It's only done over about 3 to 4 days. And after the interview, you already start preferencing sort of the regions that you would like to work in. And then after that, relatively quickly, within about 2 weeks, the initial offers come through. And then we don't really need to go through the sort of next steps after that. But that is the sort of thing that you're looking forward to now. So as we said, it's sort of end of July now. The end of November is really the big day in terms of when the portfolio needs to be in, and when the application cycle sort of officially begins, really. So there's 4 months, and the rest of the talk will kind of focus on what we can do in these 4 months to give you the highest chance of success, essentially. Okay. All right.
Hello, hi. My name is Umar. I'm also one of the ST1s incoming in the Northwest Deanery with Alexander. Again, we were in the same breakout room in the interviews, preparing with the UKRST team. And now we are in the same deanery, starting the same rotation, the same academy in Liverpool. Yes. So thank you again, UKRST, for giving the opportunity. I think they are very helpful in preparing people like us to get into radiology training programs. This is a very big favor they do for all the candidates. So always keep your eyes on what's going on with the UKRST team, because they're really, really helpful. So competition ratio is getting higher every year. I think it doubled from 2012 to 2023, more than doubled. It was 4.15 in 2012, and now it's 8.77 in 2023. And I believe the ratio for 2024 was something 11 something. The posts are going up, but a lot of people apply for radiology training. It's a very in-demand training. So it's getting difficult to get into this training every year, and that's why doing this webinar to see how we can work smart to get a national number for this training program. Because I believe there are a lot of people who are very confused, don't know where to start, don't have any idea how to even apply. Some people, like I was 3 years ago, didn't know how to apply on ORIAL for any sort of training until and unless somebody guided me. So I think maybe some of you are quite ahead, already know all of this. But I think if we can still give you some tips and smart ways of how to make you even more confident that you can get a number in radiology, even though it's very difficult. So we'll go first from the overview of clinical radiology, just touching bases. We'll come to everything else later on. So radiology is basically a 5-year run-through training. 6 years if it's interventional radiology. Nowadays, they are also giving up few posts for interventional radiology from the start. So you just do 6 years. A lot of them were in London. One was in Leeds. Quite a few in Midlands, but there was none for Northwest Deanery. So no international training program was on for Manchester or Liverpool side. But I think they probably increased that number as well at some point in time. So 5 years of training, 3 years of core training, that is basically you go through everything, and then 2 years of subspecialty training where you choose a specialty and then you train focus your training on that subspecialty and then become a consultant in that subspecialty. You CCT. So once you get into training, and if you're just going for diagnostic radiology, there's nothing else you want to do. There's no more sitting of interviews for choosing your subspecialty. You just go through it, and with the flow, you become a consultant CCT in that subspecialty. Then there are two models of training. The newer model is the academy style training. There are 5 academies in the UK. It is a bit different from the old style of training. It's few months of the first year you go through the academy. Like in my case, I'm starting in the Manchester Academy for 4 months. So in general, it's like um, simulations and teaching and lectures and everything. It also helps them to recruit more trainees. So that is one other advantage of the academy style training. The other one is like more traditional hospital-based apprenticeship, where we learn and we just see consultants working and other colleagues working, and we learn from that. I think most of the hospitals are or deaneries have this old style of training, but the RCR recommends the academy style training. I think these things are also important to know, because when it comes, hopefully when you guys are doing your interviews, knowledge of these things help a lot. The people who are interviewing you know that you have knowledge of how radiology training works and all of that. Again, the academy is like simulations and skill labs, tutorials, lectures. They prepare you for the clinical work which is coming ahead. I think it's very important for us to go through this as well ourselves and know what are the advantages and disadvantages of academy and apprenticeship style training, because it will help you in the future. I'm giving you an idea now, so you can keep in your mind that you need to go through this as well. It will definitely help you in the interviews and all of that. Then FRCR exams. So the first FRCR is part 1 is basically anatomy and physics. We take it during a ST1. It happens in spring between March to May. That's the first exam. Again, knowing this is very good, because once you get to the interview level, knowing all of these things would be very helpful. Then there's FRCR2A, which is sat during the ST3. It consists of 2 long papers sat on the same day with questions covering each radiology subspecialty. So that is taken during your ST3 year. FRCR2B is taken during your ST4. And it contains of written exam and an oral exam, rapid reporting, and long cases. Again, it's a very long exam, and I've heard that FRCR exams are one of the most notorious exams out there. But again, I think we have a big community who can help us with these exams as well. When I go through them, when I sit them, I will definitely help everyone on how I went through this experience. Then coming to this is life as a trainee. If you want to read this further, you can go to Radiology Cafe. I think it's a must read again for your interviews, because it tells you different types of trainings there are, and how is the life of a trainee during their training program. And these all questions are asked in the interview basically, and this counts as commitment to specialty, that you know what you are entering into. I will hand over to Alexander for nuclear medicine. He was rank 1 in nuclear medicine this year, so no one better to explain to the nuclear medicine incoming trainees or aspirants on how to get into nuclear medicine.
Thanks, Samar. Yeah,
Yeah.
so it's just a little bit to touch on nuclear medicine. So it's not very well known about in the UK generally, but the nuclear medicine application is the exact same sort of format as the ST1 radiology application is. So it's the same portfolio requirements, and it's the same MSRA exam and MSRA score. In fact, even when you get to the interview, it's the exact same interview for both specialties. The slight differences. So nuclear medicine as a specialty, for those of you who have not had much experience of it, I would highly recommend during your taster weeks in the future to try and spend at least a day in the nuclear medicine department, because it really is very interesting work. It's something that has a lot of potential going forward in the future. And I think it really would be kind of useful to get to know this side of radiology as well. From an application point of view, it's an ST3 in the sense that you need to have completed some form of core training prior to applying to nuclear medicine. So for me, I completed core surgical training. I completed my MRCS exams, which made me eligible to apply for nuclear medicine as well as for ST1 clinical radiology. The main thing to note is that the actual training program is very similar to what Omar mentioned earlier. So for the first 3 years, you are spending 80% of your time doing fully clinical radiology, doing the exact same exams, and 20% of your time doing nuclear medicine. And that kind of flips following ST3, whereby you spend more time in nuclear medicine and you spend about only 20% doing clinical radiology. But within that same time period of training, you will then dual CCT. So you will get a CCT in both clinical radiology as well as nuclear medicine. Although there are some slight variations to this. For example, from a surgical background, you would only get a Caesar in clinical radiology. Now, this can affect your sort of future ability to potentially move abroad and things like this, but it's either way is just something to sort of keep in mind for those of you who have previously done some other forms of training programs and want to make a switch. This really is a very good way of applying for clinical, well, doing a similar kind of training program, especially if you're very interested in nuclear medicine, as there are only 17 jobs nationally, but because of the fact that you need these kind of competencies beforehand, the application pool is a lot smaller as well, so the application ratio is smaller. But obviously as well, it makes the process a little bit more tricky, just because it's not very easy to gain these exams beforehand. But yes, it was an interesting experience. So yeah, we'll move on now. We'll go to the MSRA section of things, which is the thing that we kind of wanted to focus most on, because as we will go through later on, the MSRA, unfortunately, really at this point is the single biggest contributor to whether or not you are successful in the sort of application cycle. Really, it's the cutoff is the first kind of hurdle to jump through. So the MSRA, it's a computer-based assessment. It's done in the first 2 weeks of January, and it consists of 2 different sections of it. So there's a professional dilemmas paper, which is also known as the sort of SJT for those who are familiar. And then you have a clinical problem-solving paper as well. The PD section consists of 50 questions in 95 minutes, whereas the clinical problem solving consists of 97 questions in 75 minutes. So from a time point of view, you can see how you need to really be well practiced to get through this exam and sort of finish all the questions. The formats for the professional dilemmas section consists of ranking the sort of 5 options from best to worst, as well as multiple best answers sections whereby you choose the 3 most appropriate options. Whereas the clinical problem solving is both multiple choice and extending matching questions as well. Okay. So how to prepare? The cutoff this year was 555. Now, this is unfortunately climbing year on year. The score of 555, in my opinion, is a very good score, but it is the minimum that you need to be able to get the interview. So both Umar and I scored above 600. So we did quite well in this, and I think that we found that we both kind of prepared using similar resources and similar kind of, we had a similar kind of tactic going forward. So we would like to share this with you. So my approach was that I used 2 question banks. I used Past Medicine and I used the MCQ bank. I think you probably need about 2 to 3 months really to really thoroughly go through everything that's needed, which is why I'd recommend paying for the sort of 6-month packages for both. That comes to about £30 for the Past Medicine and about £60 for the MCQ bank. And importantly, both these question banks contain the PD and the CPS questions. I personally completed both of these question banks 3 times each. And I think it was, it's important to aim to see that your sort of your scores are climbing with every subsequent completion. And then towards the end, in the last month, I would probably say focus on some of the more official guidance as well from the Health Education England. They will sometimes send out a mock paper. There are some of them as well online. And the UKRSD as well has a lot of good resources in the WhatsApp sort of groups as well in terms of official HE papers and previous sort of SJT papers for the foundation program as well. But generally speaking, I would say aim for about 2 to 3 months, 1 to 1.5 to 2 hours a day. When you're at work, if you have an hour over lunch, just go to the library, get through 100 questions on the bus home, wherever else you're free, just go through questions. Repetition really is key for the MSRA, and you will definitely see your score improving with the more time that you dedicate to it. 100%. Okay. So in terms of the clinical problem solving questions, the way I look at this is that this is the one paper that really is completely in your control. So it's theory, it's medical theory. It's a little bit higher than the level of what they would expect for sort of medical final exams. For those of you who have done the PLAB, I assume that this is probably at a similar kind of level to those questions as well. It is a very broad exam. It consists of all aspects of medicine. It's very GP heavy, very obs and gynae heavy, very pediatrics heavy. So, for those of you who haven't looked at it in many years, similar to me in surgery, I haven't looked at the childhood vaccination schedule in 3 years. So, it's tough. It's tough going back, but you need to really, if you're dedicated to this and this is something that you want to do, the time that you put into it will 100% reflect to your score later on. I would say focus on the subjects that you're weak in. Do those questions, but most importantly, don't just kind of repeat the questions. Understanding the theory behind the answers is really important because you're never going to get the exact same question in the MSRA. The stems will be similar, but some slight changes will always occur. And a good understanding of the actual theory and the stem, I think, is the most important. So what I personally did is go through every subject, make really good notes based on that subject, get those really high sort of impact questions in on paper, know the theory behind them. And you'll find that your score between the first time you do the questions compared to the second time when you actually understand the theory a bit better will be leaps and bounds higher, really. Okay, so that is my aim for the CPS is 100%, essentially. That part of the paper, if you want to get a really good score, you need to be pretty much aiming to get more or less 100%. And the reason for that is the professional dilemmas paper, or the SJT section, which, it's the one that people really are not very happy about. So it is a situational judgment paper. It is based on the GMC's good medical practice. And the general recommendations that we would give is to try and understand the sort of official guidance. So read the good medical practice, read their official practice documents, and more importantly, the explanations for why they choose the answers that they choose. And finally, then, just go through those question banks we mentioned. They're not official documents. That's something that is very important to remember. But the more repetition you do with these kind of SJT questions, the more your mind starts to work in that way of, what would the kind of GMC want me to do in this situation? And more it actually does start to make sense. So there are some key principles that you will see will keep repeating themselves. And the more that you are exposing yourself to these questions, the more that you see these patterns develop, the more that you yourself will start thinking in this way as well. So we'll go through this in more detail later on. We will give you the key kind of factors that are important in these questions. But these are just some guiding principles for how to be successful in this area as well. Okay.
Okay, thank you, Alexander. So coming back with IMG guidance. So what I believe, because of my personal experience, is that what we IMGs face difficulty in is basically portfolio. And the SJT part of MSRA, which Alexander just went through, just be touching it again. So starting with the portfolio. So I think a lot of us lose interest in radiology once we see that self-assessment thing, isn't it? So big, 10 score, 5 score, 4 score for this, a PhD and masters, and you're like, oh, I'm not going to do this. And that is because we always think that we have to be on the top. We have to get 10 out of 10 in the first one, 7 out of 7 in the second one. That is how I believe we think generally back home. Like, you have to be on top to get the position, which I think is not correct. But it is important. But how important is the portfolio? Is it like most important thing, or is it just important? So the first and most important thing is the MSRA. It's not the portfolio, which just went through, and there's a cutoff score for MSRA. After the cutoff score, which was 555 this year, which is a very, very high score, people were commenting that, oh, I thought 510, 520 I was in, but then it was 555 when it came out. After the MSRA cutoff score, the portfolio makes 30% of the overall score. 30% is not 100%. It's even less than 50%. And your MSRA still keeps a 20% of that overall score. And the most important thing is the interview. That takes 50% of the overall scoring. I think interview is the most important bit in this application after your MSRA cutoff score, and it's not portfolio. It is important, but it is not very important like interview or your MSRA cutoff score. So last year before this, I think it was MSRA was 50%, I think, overall scoring, and interview was 30 and portfolio was 20. Now they have changed it, and I think it is good because once you you go through the cutoff score, then you can raise your ranks when you sit the interview, and there is a very high chance to score full marks in interview, but it's very difficult to score very high MSRA score. Anyways, so let's keep going. I want to go through this spreadsheet that the UKRST team collected after this year's ranks. So the person who ranked fourth in UK had a portfolio score of 31. I see people, I speak with people every day telling me I just have a portfolio score of 35. I'm like, what? 35? Just stop wasting your time on portfolio now and focus on MSRA. That is the most important thing for you now. So this guy ranked 4 with a portfolio score of 31, and his MSRA score was 615, and he smashed his interview, 58 out of 60, I believe. Yes, and he got rank 4. Just I think 2 days ago, somebody was telling me my portfolio score is 33, and I'm worried. I said, don't be worried. 33 is more than enough, because the rank 11 person, who's Alexander himself, had a portfolio score of 30. That is 15 points off the maximum score, so it's 30 out of 45. MSRA 607 interview, again he smashed it and got rank 11. First choice wherever he wants to go in the UK. Rank 39, portfolio score 29, and MSRA 603, again smashed the interview. So MSRA cutoff, high score in MSRA and a good score in interview can get you anywhere, even with a poor score in portfolio. I'm not saying this is poor, but I think 20 is poor. The rank 86 person had a portfolio score of 20, so he was still above like 200 people to get in anywhere he wants, with an MSRA score of 609 and an interview score of 54. So portfolio score 20 is like 25 points off. I think this guy can sell a pen to anyone. He's a salesman, isn't it? What would he say in the interview to score 54 out of 60? I don't know, but 20 points, I think we can get 20 points in just 2 of the self-assessment criterias, but he still got 86th rank, and he probably joined wherever he liked in the UK. Again, that is because of his good interview score and good MSRA score. I would like to know this guy because I don't know what he told interviews during the interview, and how he was able to sell himself. Again, portfolio is important. I'm just trying to get this message across to you guys that portfolio is important, but it's not the most important thing. And you can ask this guy who ranked 86. So a low portfolio score should not be the reason to let go of your dream specialty. That's radiology. Going forward, my portfolio assessment, I had a good portfolio score. I had scored 38 out of 45, but it took me like 1.5 to 2 years to get this score. I personally I have a medical background. I wanted to do high specialty training in neurology. When I did my MRCP 1 and 2, and I was working as a stroke registrar, so I felt like I should, and I was like working very closely with radiologist and mechanical. We used to send people for mechanical thrombectomy and all of that. So that is what generated my interest in radiology. And then I took a U-turn and I started working on my portfolio. And there are very smart ways to make portfolios. Again, I would like to I would like to let you to tell you guys that it is important, but not very important. So don't worry if you see my score is 38 out of 45. I don't think I got the position because of a good portfolio score. So this is a one more thing that we need to know now and this at this time is how do you um, how do you get a good score first of all, and how do you present it, and how do you upload it on the he self-assessment portal. So I'll go to the portal. I'll show you my score and everything. It's here. I'll log in. Yeah, it's okay, you guys can email me if you want. So clinical radiology. So commitment to specialty, I put evidence of, so this title is there. So you will get to do this after you cut the MSRA score. So again, MSRA is more important because it helps you get to this position. So you put the evidence title, you put the file name, and then you upload it. What I do is I do it like this. I try to put everything in one PDF. So and then I write a cover letter. So I say evidence summary for commitment to specialty. Then I use ChatGPT mostly to write all of this for me. Like what was basically my first taster week like, and what was my second taster week like in a Norfolk Center of Interventional Radiology. And then I would put the evidence like this. So this is my to confirm in radiology department from this date. 3 days. I went 3 days, and again 3 days in interventional radiology. They want 3 days. I give them 3 days. I don't give them 7 days. I just focus on those points. That's how you work smart. And they give me 10 score for this, which is the full score. Then for my radiology related managerial role, I was struggling to get this, but I think the main thing here is to think how you can do it smartly. So I spoke with one of my consultants. I said, we do this radiology meeting every week. Why don't you let me be the host on this meeting? Take notes of what discussions we do about patients, document them down, and then forward this to the patients if they need to know about what was the outcome of the meeting and all of that. He said, yeah, why not? Sure. So I became the stroke radiology liaison manager. And this is how I got my radiology related managerial role. So you don't have to you don't have to go and find out these roles. You can just generate a role, make a position for yourself in your own department if that is something that can be done in your department. So I was lucky that I was able to get this role. I made this role for myself. I said, I will do this. I will be the host. I will write down everything. I will even correspond with the patients if there is anything that they need to know and all of that. So he said, yeah. And then I did it for like more than a year. And he was happy to give me a letter that I did it. Evidence of national teaching course. This is what I did for that. It's this ratcast thing I did. They gave me 5 score for this, but they did not give everyone 5 score for this. I'm not sure why. I think they will probably stop giving full score for this one. But if they would have given me 2 score, I don't mind. I think I'll still get the position. As I said, portfolio is important, but it's not very important. I would be like what, 34, and my MSRA score is 609. My interview score was good. I would still get the rank, and I would still get in. So it doesn't matter. I was okay for losing points here. I said, okay, let them give me 2, 3, 4, whatever. I don't mind, because I don't think it affects us a lot, losing score here. Formal teaching qualification, I did the Oxford Medical 2-day Teach the Teacher course. I put a cover letter like this. I told them what I learned through that course, like that, and then I put the certificate in, and they gave me what I wanted, a 2 score. Poster presentation and international and national level. A lot of people want to publish case reports in radiology or research or whatever. What I did was very simple. I booked in for a conference. I put an abstract in. I put this like, this is discuss the importance of identifying cerebral venous sinus thrombosis and significance of MRI brain. So this was a stroke conference, but I sold them it as if like it was like, it is rated to radiology. Yes, it is. And they give me full score for that. So it's like a MENA stroke conference, not full score, the score I wanted, 3 score. And this is my abstract. So I put the cover letter, then I put the certificate, and I put the my poster. And they gave me 3 score because it's a radiology related abstract presentation. That's why I keep telling people that even if you publish a case report, you will get full score because it is radiology related and it is in a peer reviewed journal or whatever they want in their self assessment. Lastly, prizes and awards. Again, there was this interview course in our academy in Norwich. So I put my poster in and I got first prize for it. Prestigious East of England Academy organized open day, an annual event. I put a cover letter in, and then I put my certificate, and then I put my poster. So this again is stroke related, but it has a lot of radiology in it. So just find radiology in your department and then work on it. You don't have to like go through radiology based things to get things done, because radiology is everywhere. It's A&E, stroke, neurology, endocrine, everywhere there is radiology. We have weekly endocrine radiology meetings, weekly vascular radiology meetings, weekly stroke radiology meetings. So whichever department you are in and you have those meetings weekly, which I think there are in every NHS trust, ask your consultant that you want to host it, and then there you go, you get a managerial role in related to radiology, local. So going back to the presentation. Great, there you go. Okay. So that's my feedback from the person who checked my portfolio. They said, no, our scores were the same. Give me 10 for commitment to specialty, 5 for leadership and management, 5 for teaching and training. I don't mind if they give me 3 here as well, because I really don't think it would have affected me in any way. I would not, even if I was like 10 ranks down or 20 ranks down, I was still safe to get in. I was way above 300 post cutoff. Audit and quality improvement, they gave me 7. Academic achievement, they gave me 3. Prize and awards, they gave me 6. That's full score. So the person who scored 20, I would have scored 1, 2, 3 just here. So if I had 0, 0, 0, 0 here, and my MSRA score was better than him, my interview score was lower than him, he smashed the interview, I would still have gotten the position by just doing this, this, and this. So there was no need for 6, 3, 7, 2. Again, it is important for me to have it, but it's not very, very, very important for me to have this much score. 10, 5, 5, 20, 609, interview 50, you're in. So I think after when you have like 2 months to go for the MSRA, I think you should just stop thinking about portfolio if you're above 25, because I think MSRA cutoff is very important and also is very significant, and your interview is very important. So this is for my IMG colleagues to reflect upon, that portfolio is not everything. It's difficult for us to achieve all of the requirements of the portfolio because we come from countries where portfolio is not very significant. You can get into training by just passing an exam. And that's why, and we were never taught to work on portfolios during our medical school. Audit is, when I first came to the UK, the first time I heard about an audit. I first heard about leadership roles and all of that. So that is why it's difficult for us, because we come to know about it when we come here, and we are the people who graduate here have a head start, so they are above, they are far away from us and very ahead of us. But going through this, I'm just trying to tell you that just relax and work on your MSRA and interview, and you will still get the post. And now MSRA SJT, which is the second thing that I personally had difficulty going through this one. Now this is not like portfolio, this is very important. Yeah, it's like my MSRA score was 609. SJT is very, very important. my SGT score was 288 and my clinical score was 321. My SGT score is still not very good. People score above 300 because, and they try to score more on this one, so to get complete benefit from the scoring system. My first MSRA when I sat the year before this was 507 and my SGT score was 192. I prepared only for 1 month, and when I opened the SJT, I smirked, I smiled, I said, "Oh, what is this? It's funny, isn't it? Well, a nurse had a breakdown. What will you do? Oh, I don't care, but I have to, isn't it now?" So um, I did not go through that SJT properly, and I scored 192 in that. My clinical was still 320 or something, and I only scored 507. The cutoff was 530 or 540 something last year. I'm not sure. So I missed that cutoff, or 521, I think. And then I was like, okay, I know where I went wrong, and that was the SJT. So SJT importance is extremely high. My SJT resource, just like Alexander, was Past Medicine and UKFPO papers. They're available on the UKRST WhatsApp group. You can download them from there and go through them. There are two parts of the SJTs. The first part is you have to rank in order what you think is the most correct response, then second, then third, and then fourth, and then fifth. And the part two, you just have to choose 3 of the 8 possible responses. You have to know all of these things because you have to know the basic foundation of the SJTs to score high on it. Because what I did last year was I thought it's very easy and I'll just how can I not know what's right and what's wrong, and then I'll just go through that. But so I work as a registrar here, so my level of thinking on that exam day was I was focusing on it as a registrar. But if you go through the MSRA bits, you have to answer these questions as if you're on FY2 level. So that's also an important thing to know. You need to escalate and all of that, which we will come to just now. So the core criteria in SJT. So they assess you on these core criteria. So every question comes from these core criteria. It's empathy and sensitivity. So once sometimes they ask you that the nurse had some confrontation with the patient and then she was crying, so you have to empathize and you have to be sensitive. That's a core criteria. Communication skills can be with the patient or with your team members. So they can ask you would you like questions on communication with the patient, and also questions on communication with your team members, and as on FY2 level. So you would need to know how to communicate, so when the question comes, the first thing you should think about is what core criteria are they judging me on? Is it empathy and sensitivity? Is it communication skill? And that will make it easier for you to answer and put the orders of the answers for your question. Conceptual thinking and problem solving, again, it's a core criteria. Coping with pressure, so they're like, you have 10 jobs on the ward and your other FY2 has called in sick. What will you do? That's coping with pressure. That's a core criteria. Organization and planning, so you have a best friend's wedding coming up, something like that, and you have an on-call. What would you do? You try to swap the on-call, or you just not show up. So if you try to say, I'll swap it, I'll make plans in advance, that's the first correct thing. I won't show up would be the last thing. So you know that they are now assessing my organization and planning criteria, and then you answer it on the basis of that. Managing others and team involvement, so again, that's a core criteria. Professional integrity could be confidentiality of the patient or confidentiality of your team members who come and tell you something personal, and then you have to keep it confidential. So all of these questions, like they all come from these core criteria. So how did I tackle my SJTs? I think practice makes perfect. We need to understand these core criteria, the concept of them, and then it becomes very easy for you to answer these questions. If you know the core criteria on what they are assessing you on at an FY2 level, then it becomes very easy for you to answer these questions and feel relaxed when you answer them as well. Because it's very difficult to know which one is right, which one is wrong, but it's very easy to know which one is absolutely right and which one is absolutely incorrect. Eat, sleep, do these questions, and then repeat. And just don't panic, relax, and you should know how it is scored, which will come to, and what will happen, magic, and you will have a very good score in SJTs. So I will go through this first question now. Just just trying to see how the questions are like. We'll just do the part 1 bit, not the part 2 bit. I think there is another webinar might be later on, which they will go through this again. So we'll just do this a few questions. I will take one, and then Alexander will take one. I'm happy for any one of you to put an answer in the chat box, and we can score we can tell you how it is scored basically. So if guys can read, your consultant, Dr. Jackson, has asked you to prescribe a second antibiotic for a patient who has a chest infection, which has been slow to respond to initial treatment. Later that day, a pharmacist informs you that the new antibiotic is not in the hospital formulary. She tells you that the new antibiotic should not be used because of the risk of C. diff infection. So I will just wait for an answer, and anybody who can answer, just answer, and then we'll see how correct that is. Here's the chat box.
Oh, Mari, I think you might need to open the PowerPoint for them to see the
sorry.
question and everything again. Yeah.
Yeah, just
Okay.
keep it open. Yeah.
Okay, you guys can tell me when somebody answers and what their answer was. If nobody wants to answer, I'll just go ahead.
You can also send us. You can also message in the chat box if you want. We'll give us a minute.
Yeah.
Yeah.
Sorry.
And I think this is the other important thing as well is like remember in terms of how many questions there are. So you have approximately 1.5 minutes to answer these questions. So the closer you get to the preparation stage of the actual exam, the timing is important as well, because you can sit here for 5 minutes and look through each question, but the timing as well is the other thing that's really important.
So
there's no negative marking, so you need to better just answer things as opposed to leaving empty questions.
So we have several answers in the chat box.
Let's see the first one, yeah?
Yeah. The first one is from Rifat Hassan. He answered CDBEA.
CDBEA.
Yep.
Okay, thank you. Let's see. Yeah, so it's a CBDAE, not CDBEA. Okay. Heartbreaking, isn't it, Rifat?
So there is one person who got it in the same. It's Faisal. She answered CBDAE at the end.
Excellent, Faisal. Yeah, so you are in the lead, Faisal, and Rifat, it's heartbreaking. It's okay. It was same for me. It happens like that. So we just need to know how it's scored. You can always read again and make improvement. But the answer was basically assessing the core criteria of personal and professional development in how you would learn from this, that the pharmacist says that this antibiotic is not in the formulary and blah blah, and what you can do to help. So the first is C. They said who let's go. Agree to contact Dr. Jackson to discuss the prescription. Okay, that is the best response here. You need to do that. That's for your own personal development. You will learn from it why he chose this and other antibiotic. So you have to think like that. And the second was D. So ask your specialty trainee. So you escalate it to your senior if you cannot directly discuss with your consultant. B is you tell the pharmacist that Dr. Jackson is away. Maybe you can call him and ask him for his advice. E is do not change the prescription and make record in the notes for the pharmacist concern. And the last one is prescribe what the pharmacist advises. Yeah. So Rifat, your answer was C. So C was fine. Yeah. And your last one was A. So the main thing is that just the middle ones were here and there, D, B, E, but the first one was C, which is correct. So you get 4 score for that. The last one was A, again, that's correct. You get 4 score for that. So you are 8 now. And then you placed D second, but the D is actually third. So you would get 3 score for that. So if the applicant ranks D as sorry, you scored it, yeah, as 2, so you will get 3. So it's another 3 for you. Then you scored B. So if the applicants rank B as 3, you will get another 3. And then you scored E. So if the applicant ranks E as 4, you ranked it 4, you still get 3. So you scored okay, 17, I believe, isn't it? Yeah, 17 out of 20. That's not a bad score, isn't it? So again, relax. It's fine. It's scored like this. If your order is like the main thing is that what you did correct is that you scored the top and the last. So that is completely fine, because if you mess that up, your score can go down. In the middle one, you scored 3 in every one, so just one point less, and it won't affect your score massively. So you still score good, and that is what we need to know to relax, to just to make sure that we know that we won't get a 0 score if our order is not in the same order as the answer. So this is how it is marked. We need to know that, and we need to know what core criteria they are assessing us on. And this is how we tackle with the SJT. I'll give the second question to Alexander. His score was very nice in SJT, so you probably learned something from him as well.
Thanks, Savar. Yeah. So I'll read the question out, and then let's do the same thing. And then this time I'll sort of work the way like my mind would work looking at this. So the question is you're looking after Mr. Kuchera, who has previously been treated for prostate cancer. Preliminary investigations are strongly suggestive of a recurrence. As you finish taking blood from a neighboring patient, Mr. Kuchera leans across and says, "Tell me honestly, is my cancer back?" So these are the 5 options here. Have 30 seconds to a minute. Again, if you could put them in the chat box, that would be great. And then we can work through them together just to see what would be the kind of the big factors in this question. Okay, yeah, there's some answers coming through. Good. Okay, another maybe 10, 15 seconds, and then I'll start going through it. Good. Okay. Fine. So we'll go through what the right answer is. So let's just look at this question. So the way when I look at these questions, the biggest question is, first and foremost, for the GMC's point of view, is patient safety. Patient safety is always the biggest kind of factor that they care about. So Omar, do you mind just going back to the previous slide just for a second? Yeah. So if we look at this here, what are the patient safety implications first of all? So this patient probably has cancer recurrence, and he's asking you, has it come back? So which of these options, if any, will cause a patient safety problem? And I think that B, where you're reassuring him that he will be fine, whereby you're basically telling him, you're cancer-free, you're good to go, that is a definite patient safety concern. So that option is pretty much the only one there that will cause a true sort of patient safety problem from a health point of view. So that should be last. I think that we can agree that reassuring him that he's fine, lying to him, false reassurance, the worst option. And then the second thing as well is then what they also want to assess here is, are you acting within your level of kind of competency? So as we said here, you are an F2, you're not a urology consultant. So you are not the best person to be discussing a patient's, metastatic recurrence and the sort of next best options. Hence, they're assessing your ability to understand where your competency is and at what point you need to escalate and to who. So the best option is you don't have all the answers yet. So fully telling him that the cancer's come back isn't the best option. So it's either going to be telling him that you don't have the test results, you will come to speak with him when they do, or that you will go and get your seniors to speak with him when those results come back. And what the answer is, and also what we think is the best option is that really this should be a senior conversation, hence D is the best first option, because you're being honest with him, the results aren't back yet. You're not telling him straight out he's fine or that the cancer has come back, because you don't know that for 100%. And B, it's not you who will speak to him, it will be a senior who will speak to him and who will be able to break the bad news effectively and who will be able to go through the implications of the results as well as what the next steps are, because that is the important aspect of breaking bad news as well. It's not just telling him, yes, your cancer's back, it's also what do we do from here. So the way that they then ranked it, so they said, D is first, you'll ask your senior to come back. They then said that the next best thing is you speaking to him, but obviously there is the risk that you will not be able to answer those questions. Following that is taking him to a room, getting a colleague to hold your bleak, exploring his fears. So the wording here is really important. It just says you're exploring his fears. You're not breaking the bad news. You're not telling him anything. You're simply exploring what he's worried about, and what you do going from there. So there's no patient safety concerns here, but similarly, you're not really answering any of his questions. You're simply exploring his fears. And then what they said as well is that because somebody else is holding your bleep, there are some problems there, because that means that you might not be, doing the job that you're meant to be doing, that your colleague might be taking on a lot of work for you, and there can be some concerns from that. And the two worst options are either, one, telling him his cancer is back, and B, reassuring him that he'll be fine. So this is the kind of way that whenever you look at the questions, I think the first thing in your mind is the worst option, which is the patient safety concern, breaking confidentiality, lying to the patient, lying to the law, for example, if there's questions about you, getting a speed ticket or whatever. And then the next thing is, like Umar said earlier, is what is the best option? And the best option is one where you are showing some initiative in tackling a problem, and also acting within the limit of your competency, and sort of escalating it sort of in a successful way, as opposed to just taking it straight to the consultant or somebody else. So yeah. So we can go through the next slide now and just see exactly what they've written. But this is the general sort of way that things work. So I see most people are getting the first and the last one right. It's the stuff in the middle, which, honestly speaking, as long as you are acting upon those kind of key principles, majority of the time you'll do well. Somebody earlier as well said there's a lot of discrepancies in the past medicine resources. It is what it is. This is, we're all medics. We think in this kind of way that we like to know theory, and we want things to be right, which is why, like I said, the clinical problem solving questions are the ones that you need to aim to have 100%. For SJT, as long as you know the principles and you rank things according to those principles, more often than not, you will be fine. You might not get 100%, but like we showed in the last example with Umar as well, 17 out of 20 across the board is an amazing score for the SJT. So, if you have one or two wrong, that's fine. But if you find that your whole kind of setup is the wrong way around, then really you need to focus on those kind of core principles, and in terms of what you need to prioritize, and kind of training your mind to pick out the concerns in each of the questions. Cool.
Excellent. So we'll go through one last question. I think you had 5, but probably running out of time now. Again, yeah, very absolutely correct. You cannot score 100% on SJT. It's not like a medical question. For instance, stroke, what will you give? Aspirin or thrombolyze within 4.5 hours, whatever. It's not like that. There's no straight answer. But there are two things that can be done. Most of the times can be done like 100% correctly. Is the first thing and the last thing. The middle ones, what I did was I used to think about scoring 3 in the middle ones, because if my thinking is that I need to score 4 on each of them, I think because of my stress I would fail the exam, and I don't like to take stress. My thinking was, let me get 4 on the first one, let me get 4 on the last one, and 3s in the middle ones, which Riffat did. He got 4 on the first and the last one, and 3s in the middle ones, and he scored good. And that is what my thinking was. If I was doing past medicine, or if I was doing UKFPO papers, whatever it was, I think there would be questions like, oh, the discrepancy, as Alexander said, but I don't think there would be discrepancy in 1 and 5. There could be discrepancies in the middle, and mostly those discrepancies make you score 3 or 4. They don't go to 2 or 1. So I would just think of it, past medicine, my first should be right, my last should be right. If my middle ones are 4, well and good. If there are 3, I'm happy. I'm more than happy. If there are 2, what is it I'm doing wrong? What is my where did I get it wrong, or what concept I did not understand? So I learn from that. But if it's 3 or 4, the middle ones, I'm happy. I don't mind that. So my first and last one should be 4 and 4. My middle one should be 3 or 4. 3, I'm still more than happy, and I think that's why I scored 288, because my first was 4, last was 4, and in all the questions my middle ones were 3. So that's why I scored probably 288, and that's good score. That's not a bad score. Now let's go to the last question. At your morning handover briefing, you are reminded by infection control that all hospital staff should wear shirts with short sleeves. When wearing long sleeves, they must be rolled up and secured, particularly when having clinical interaction with patients. During your shift, you notice that your FY1 colleague always has her long sleeves down. So I'll just take an answer, first answer, and we can score the person who answered that question, and we'll see if they go wrong. If they score less than 17, whether they went wrong.
Yeah, we have got lots of answers. Some people are saying B is the first one,
Yeah.
and the last one is D or A. So I'll just say a random D,
Yeah, just say a
B,
random
E,
answer.
E, A. Yeah.
Sorry, can you repeat that, please?
D, B, E, C,
Yeah.
A.
Thank you so much. Yeah. So it's a B, C, E, D, A. Now somebody got the first one incorrect. And B, you still score 3, because if you score B as second, you will score 3. Then the second but you score D as the first one, so it is actually the fourth one. So if you score D as the first one, you score 1. Yeah. So 1 for that. And then you scored B as your second one, you'll score 3 for that. Then you scored E as your third one, you'll get 4 for that. Yeah. You scored C as your second last one, and if you do that, you will score 2. And you scored A as your last one, and it's the last one, so 4. So 8, 10, 13, and 14. 14 out of 20. Yeah. So 14 out of 20, I think it's the average score. It's not a very good score. But again, you don't score 0. You didn't score 0 in any. So some positive out of it. You can score 0, see, 0 and 0, but you didn't. You scored 1, which is not good. So when I said whenever I score 2, I see why I did it. Whenever I score 1, I get upset, isn't it? So I have to then learn that what mistakes did I make. So this question was basically assessing your communication skills with your teammates. So you chose D as your first option. Do not say anything immediately, but monitor the situation over the course of the next few days. So I think this is absolutely not absolutely second last time wrong, because and that is because it is patient safety, as Alexander said in the last question. If she's doing that, so this protocol is in place for patient safety, and you have to communicate this to your colleague. So this is your communication skill. So these are the core criterias, but all of these core criterias lead to patient safety. So everything you do, they're assessing your communication skill and how you would communicate in circumstances which will help your patient, isn't it? So if you don't say anything, she probably carrying some infection, and that is against the guideline, and then patients are at risk of infections from that. So I think that is why it is wrong. Then your second one was B, and the B is the first option. So speak. No, I will not go through B, because B is 3, and I'm happy with that. I will go through the one you got wrong. You scored 1 and 2, and I'm happy with 3, 4, 4. So you got D, and that was your score 1. The other one was you got. Yeah, C. You put C, isn't it? You put you put C in second last, whereas C is that. So C, raise your observation with nurse in charge of the ward. This is very important. So as per the thing, you should first speak to the person who is involved. Speak directly to your FI1 colleague. So you have to communicate with them. So if you see something wrong and it's your FI1 colleague, what's the problem of in going and talking to them? That's your communication skill. Probably when I was back home and I came here, I would do the same thing, not tell them and just observe them, maybe just ignore it. But when you are here, you need to know this, why everything is in place, why all these core criteria are in place. That's for patient safety. And as doctors, we are not here just to prescribe, junior doctors, we're just not here to prescribe medications, prescribe fluids and give her autograph on that, the IV fluid autograph, give it to the patient. We are here to make sure that the NHS works within the framework it is meant to work. So we make sure that all of these core criteria are in place, and for patient safety. So when I see someone, I need to go and communicate with them, tell them that please don't do this. It is against infection protocol guidelines, and you are putting patient at risk. So that is why B was first, and it should and it should be first, because I need to communicate with them. The second thing is, you raise concerns with the nurse in charge in the ward again. So if you feel like you cannot speak with a 5-1 colleague, which you should be able to do that, you need to tell someone who can take action. So the nurse in charge of the ward is again is in the answer. It's in the answer, in charge of the ward. She can go and talk to their 5-1 colleague and tell her, please, can you stop doing that? It puts patient at risk. So I think these were the things you need to remind yourself of, that patient safety comes first. And if you have, and you are being assessed here on the core criteria of communication skills with the team member, so you need to communicate. So when you're being assessed on the core criteria of communication, that means they want communication from you. They don't want you to sit tight and ignore it and see over the last few days what happened the next few days. I hope that makes sense. Okay. Um, thank you. So top tips, I'll let Alexander go through them first.
Yeah, I think we'll just sort of reiterate everything we've said. So I think the biggest thing is it's end of July now. For the portfolio point of view, you have until the sort of end of November to have everything in. I would prioritize the biggest scoring sections. So the taster weeks, teaching, audits. Those are the ones that I think, if I remember best, are the 10 points. So if you have those, that's what 80% of people will have. You're fine. If you can get some of those higher points as well, fantastic. Make your life a lot easier later on, give you some breathing space for everything else. But first and foremost is MSRA. Really, focus on that. 3 months is more than enough time. 2 months as well is probably okay. But the thing is once you're doing the MSRA, treat it as a serious exam, do it regularly, build up on everything you're doing, and just keep going from there. And then obviously we haven't included it here, but I think just, UKRSD, keep doing everything with them, keep on top of their webinars. They have training sessions later on for interviews, which are amazing. I think you're already probably ahead of most of the other applicants by doing this on a Saturday, 4 months away from the application. So keep up with that. Make a good personalized plan for what you hope to achieve in the next couple of months. And if you have anything that we could help with, we're more than happy to obviously do that and give you ideas for what you can do for your portfolio. Join the WhatsApps, and I think that's it really.
Okay. Yeah, thank you guys. Just to summarize again, MSRA is very important. Again, as Alexander said, very, very important. For IMGs, SGT is very important. You need to know how they are scored, and we went through that. And what is the most important bits, how to rank them. First and last are more important. In the middle ones, you need to score 3. That was my way of doing it. I didn't mind if I scored 3 in the middle ones. I did read upon it if I scored 2 or 1, and why. So keep repeating your SJTs. I think past medicine and UKFPO's papers are enough. That is the only resource I used. I did not go through MCQ Bank SJTs. I only used past medicine and UKFPOs, and I would repeat them. I did like 3-4 times the UKFPO ones and 3-4 times the past medicine ones. I would not repeat them like every other week. I would give some time for me to not remember the answers and then go through it again. And I would read the concept again. It's very easy to do these questions, and because they are very quick, you can do them quickly. But the main bit is to read why is the answer like that, or why are they ordered like that, and then to know the concepts of the core criteria, to make sure that you know them and how they lead to patient safety. When you're communicating with someone, you're doing it for patient safety. When you are doing professional development, you're doing it again for somewhat patient safety, confidentiality and all of that. So you need to know the core criteria. You need to you need to continue doing these questions again and again to get a good grasp of it. Again, 2 months, as Alexander said, is more than enough for all of these things. another important message to take home is portfolio is not the most important bit. You can have a 20 portfolio score and you can rank 86th nationally with a good MSRA score and a good interview score. So anyone who is right now in this in the shoes of a person who scored 20 in portfolio, you can also relax after listening to this webinar and focus on your MSRA and then later on your interview. Thank you, guys. We're open to question and answers.
Hey, thank you so much, Umar and Alexander. That was like a fantastic presentation, brilliant. I really loved it. And some great tips on MSRA and especially on the portfolio also, although we are doing a separate webinar on this, but I really like the way Umar showed his portfolio and like, the way you can see that he really put the effort in. So I'm sure Alexander also, but because I've seen his work, so I can see like how he has arranged all the things, like he has written cover letters, then he has like put all of them in the same box, like everything, like a cover letter along with a certificate or whatever the prize was. If there was a poster, then he linked the poster with it. So everything is like, it has to be very organized. So I would say radiology is becoming really competitive and you have to work hard. There's no shortcuts now. And of course, portfolio is not the definitive, like it should not be something which should bog you down. But of course, if you have more marks, it will give you an edge. But you have to put in effort in all the bits, like obviously from the starting stage, if you're preparing for your portfolio, then when the time comes for MSRA and even for the interview. So you have to be your best in every stage, especially if you're very region specific, I think. And the second thing I think to take home is like you have to work smart. You also have to work hard, but then you can claim points for different things. For like we're thinking in one box, like, oh, I have to get this radiology related, like, peer review publication or anything. You might not be someone who is like very research oriented. I'm not, and I've completed my radiology training, got a consultant job. It's fine. I have some publications, but nothing in like as a first author. So I think yeah, that's the most important thing. And so I specifically asked them to put the MSRA questions so you can see how different people approach different questions. I know Alexander has to leave, so Alexander, if you have anything to say, really big thank you for joining in on a Saturday morning. So I'll let you go early if you have any last few words, and then I think if Umar, we would like to stay for 10-15 minutes, we can wrap up like any Q&As if we have any.
Yeah, just again, thank you all. Yeah, I look forward to being in touch with you all over the next couple of months. If you need anything, by all means, through the WhatsApp and every other way, reach out to us. And yeah, good luck. Just work smart, and it's definitely achievable. Don't get stressed by the 11-to-1 application ratios. Yeah, so someone has to get in, so why wouldn't it be you? So yeah, all right. Thank you all.
Thank you, Alexander.
Thanks. Bye.
Thank you.
Thank you, Alexander.
Angelica, would you like to go through some questions if we have not answered any in the chat box?
Yeah, so just before answering some questions, just a reminder that there's also a link for the feedback form for our wonderful speakers who have taken their time to share the information that is very useful, sharing a lot of information that you can definitely work on so that you can improve or prepare for the application. So the feedback form has been posted by Sadaf, so please do take the time to fill that out. So some of the questions, most of the common ones was how can we join the WhatsApp group? So to join the WhatsApp group, you can either email us at ukrstteam@gmail.com. I believe that's correct. And if you can email us your number, then we can add you on as quickly as we can. And then there was one question on the chat about, I think, what's a portfolio. So again, a good idea on what a portfolio is and what can you do to make it a good one will be tackled next week on our webinar. So that's on July 27, the Saturday from 4 p.m. We'll post details on it as well. But I guess it's best for you to actually ask Umar while we have him here. So the other questions we'll try to just answer as we go on the chat.
Okay, so someone is asking, applications will open in October. So I think, yeah, they open in November in the first week. So you have to keep an eye on that. In the meantime, you can read up the person specifications for clinical radiology. If you have to get the CREST form signed, just make sure it is signed beforehand and the correct CREST form is signed for that year. One thing I wanted to ask Umar was, like, for the MSRA prep, did you do it by yourself, or Umar, did you benefit by doing it with someone?
Yeah, so I did it by myself. I just used the past medicine and UKFPO things. Again, as I said, that I would not stress myself by discussing with someone else because they probably score more than me. I was not very strong in my SJTs. So I would just make sure that I'm scoring 4 in the first, 4 in the last, and 3s in the middle. So just keep it simple for myself. Because as long as we think that we need to score full, I think this is where we lose it. But I think it is beneficial if you do it with someone who knows more than you, so you can learn from them. That is the key, I think. If you learn from someone who is better than you, and don't stress, just learn what they tell you, and probably if you are too weak in the MSRAs, so I would just first go through them, and if I'll see how I am doing. If I'm doing good, that's well. I just keep repeating the questions after a month or so, and make sure that I'm going through it again and again. But if I'm scoring 1 on the answers, then I think I probably need help from someone to see what I'm doing wrong if I cannot get it right. Yeah.
Okay, great. Yeah, I think that's the right approach. It's more like studying for exams also. Everyone is different, but I just feel like sometimes um, if you're not up to the mark, then you might benefit from someone who knows more and who can guide you
Yeah.
in a better way. And also you have to make use of your time also, because everyone has a different
Yeah.
work schedule and everything. So yeah, good. Taster weeks, I'm not sure some people ask about it. We'll touch on the portfolio, but make most use of your taster weeks. I know you keep getting lots of questions in the WhatsApp group, like about 2 taster weeks, doing in a DGH. So if you're here, I thought probably if you can clarify that.
Yes, of course. So I did both the taster week in the same hospital. To be very honest with you, my first taster week involved interventional radiology as well. It was like for 3 days. One day was interventional radiology, but then I did another one for 4 days in only purely in interventional radiology, going through different cases of how they do peripheral vascular things and all of that. People, when I was applying, people told me no, they won't accept this because it's the same hospital, and you have to go to DGH and tertiary hospital to get a different setting. But my thinking was that intervention is a complete different setting than diagnostic radiology. So I just went with it, and I then put a cover letter that my first 3 days were in clinical radiology, and this is what I learned. I went to the academy. So just like one paragraph of what I did, just summary, and you can just put it in chat GPT and it'll give you an answer of just summarize for this for me, and it will summarize it for you. I went to CT, MRI, and academy, one day in academy, and then I wrote another paragraph for what I did in intervention radiology, and then I put my certificate for the first one and then for the second one. And my second certificate clearly mentions that I did it only in intervention radiology, and I got full 10 score for it. So if you do it in DGH or tertiary, you get full score. If you use the same hospital, but if you do one in intervention, one in clinical radiology, you get a full score. If you do in the same hospital, one taster week, and if you attend multiple MDTs with the radiology team, you still get full score, because that's another way of achieving full score. And yes, so the self-assessment is online. You can just write radiology self-assessment, and it will come up and it will tell you what you will score by doing what for your portfolio.
Okay, what exactly is academy radiology training? So academies were basically started off a few years ago just to have like more cohort of trainees in a bigger scheme. And the way it works is like you spend like almost like 50-60% of your time in academy, which is more like you have pre-populated PACS images on the in the system, and then you go through them. You also have simulators for ultrasound. So you probably in your first day you might be spending 2 or 3 days in the academy, 2 days in the hospital, and also because you have teachings in ST1 for physics and anatomy. So that's how the academy model works. And as you progress academy and more in the hospital setting. So there are a few traditional radiology academy schemes when they started off. One is in Norwich, one is in Leeds. So in Manchester also they have merged. Some of it is like now academy-based teaching. And then there's one academy in Peninsula and another one in South Wales. So don't worry too much about the academies. I would say I have basically trained in conventional radiology schemes and traditional, but even in those schemes now, a lot of teaching is now academy based. Like for example, Oxford is now merged with Wessex, and the trainees, they do have teaching on teams. So it's more like a Southeast Imaging Academy, SIA, but then they're not going to another center for academy teaching as per se. So, and these things, they come down when you're ranking your training scheme. So don't get too much worried about that. You can, if you don't want to go to an academy, you can even rank the places which only have in-house, like in hospital attachments. So if you have the few portfolio related questions, so if you can join us for the next webinar on next Saturday, we'll post the details so we can answer more of those in the next webinar. Yes, we have recorded the session, so it will be shared on our YouTube channel. And if you've also joined our WhatsApp group, it will be shared there. And you can find all the links in the description. Okay. Hi, Omar. Someone is asking, where can I look for these regional imaging academy meetings to present posters or projects? I think it's
Yes,
the
thank
place where you're working. Yeah.
Yeah,
Yeah,
so
you
you
can
can
answer.
also, because this Norwich Academy, the one in east of England, the annual day is open for everyone. So it's like a national annual day, and they have this poster presentation as well. So if you just go to their site, East of England Imaging Academy, and I think it happens in November or end of October. So you can just put yourself down for it. I think it's 150 quids or something for the annual day. They, which includes an interview session and a poster presentation, and it's a very good opportunity to grab a prize because they give a prize for the first poster presentation. Anyone who they give a prize for the best poster presentation, and the other thing is that there are not a lot of posters in that because maybe 5 or 6, so you have a good chance of winning that. And again, it's a national annual event from a known radiology academy institute, so you'll get full score for that prize if you grab it. Again, the other academies which Abira just talked about, you can also go on their sites and see if they have an annual day. So you have to work on it smartly. Just go on their site, Peninsula Academy or whatever, and they all of them always have an annual day. And they have this poster sort of presentation. Ours one definitely has. I think it will happen this year as well. It's called the East of England Imaging Academy. You can definitely participate in that. When I did it, there were people from London, people from Midlands who came to the annual day and also brought their posters. So it's a good chance of winning that a radiology related present award. Sorry.
Okay, great. Thank you. So yeah, just before leaving, I would like to say, please fill out the feedback forms. It's really important for us. It's also good for the presenters. We'll give them certificates, and also for us to improve for the next webinar. And if you have any questions, you can still ask in the WhatsApp group. It is quite active, and someone is always there to answer the question. So yeah, I think we'll just wrap it up over here, Angelica.
Yeah, so thank you again to our speakers and to everyone for joining. If anyone wants to be added onto the group, again, we have Dahlia. She's actually one of our team members as well. Hi, Dahlia. she mainly runs the website and the email group. So if you could just email us at ukrstteam@gmail.com to be added onto the WhatsApp group. And please don't forget to fill out the feedback forms. Thank you.
Thank you.
Thank you, everyone.
Thanks, Emma. Okay.
Thank you.
Bye.
Bye-bye.